You're listening to Finding Fortitude, a podcast that aims to help former athletes take good care of their minds and bodies through sustainable, evidence-based health habits. I'm your host, Dr. Tori Williams, a physical therapist, coach, and fellow former athlete who is ready to be part of the change in healthcare and who is on a mission to learn and share about all things health and well-being so that you can be equipped with the knowledge and tools to live your best life. As a reminder, nothing shared on this podcast should be considered medical advice. Let's get started. All right. Hello, everyone, and welcome back to another episode of Finding Fortitude. If you know someone who has ever experienced an ACL injury, or if you have experienced an ACL injury, you're going to want to listen to this episode and take some notes. Today, I am joined by another really awesome human and someone who I have looked up to personally as a mentor since I was a brand new physical therapist 5-6 years ago. She is a doctor of physical therapy and orthopedic clinical specialist and the founder of ACL Resolve, an online business that provides virtual coaching services to athletes after ACL injury and ACL reconstruction. She is also the co-founder and lead mentor for an online mentorship and clinical certification program called Clinical Athlete, which is how I came to know her initially. She is truly one of the best in the game when it comes to ACL rehab, which is why I'm so incredibly grateful that she was willing to come on the podcast so we can all learn from her. So without further delay, welcome to the podcast, Steph Allen.
Wow, that might have been one of the best intros that I've ever had. I appreciate that.
Of course. Thank you so much for being here. So today we're going to be talking a lot about basically all things ACL, from initial injury to rehab to returning to sport and performance, which I know is your world. This is a huge topic, so I know we'll be just scratching the surface today. But before we dive into all of that, would you mind telling the listeners a little bit more about yourself, including your athletic background?
Yes. So I grew up kind of doing a mishmash of things. Again, now it's funny being a PT and like trying to shout from the rooftops, like, have your kids play multiple sports. Please have your kids play multiple sports. I just feel like that was what, when we grew up, like that's what people did. Lo and behold, now it lowers your injury risk, but that's a whole different conversation. So I kind of bopped around to different sports, started gymnastics really young, did diving, softball, basketball. I had a short stint in cross country. I hate to admit this, and not for against any other of these athletes, but I hated cheerleading, but I did it for a while because I was the only one on my team that did. I tumbled, a very small town, so of course, if you've ever done it, you get scored for tumbling. I was that person, so they kept convincing me to come back. But my kind of true lasting sport was basketball. Started playing more seriously in like second and third grade. Started playing AAU after that, and that was really I feel like how I identified. I was a baller, thought I was going to be in the WNBA, that kind of thing. But yeah, I grew up in a really small town in New Jersey. Ended up tearing my ACL in high school playing basketball. And I didn't have the resources / nobody in my family had been seriously injured. It was 2007, so PT for a high-level athlete after an ACL injury was worse than it is now, which some of us can imagine. But again, I think, press fast forward, it was always something I was interested in when I ended up going to PT school. I wanted to be like 4 or 5 other different doctors at some point. Went to PT school. It was always in my mind as something I was interested in. And then when I was doing travel PT for a couple of years after school, I think that's where it really sunk in terms of like motivation for me wanting to just really dive deep and make this my thing, my specialty. It was because I was working in all of these different states and nowhere seemed to have a good approach slash system, whatever you wanted to call it, for working with people with torn their ACL injury, young athlete or not, just anybody. And I found that like, I don't know why, I just remember distinctly thinking like, how is this bad everywhere? So then that was it when I started working at a really kind of um, awesome sports clinic in Boston. After that, I was there for almost 7 years. All the continuing education, mentorship that I could in the ACL realm, reading everything. And by the time I left the clinic and started ACL Resolve, what I'm doing now, I would say my caseload was probably like 90% ACL, which definitely was the goal. But then I got to that point and I was like, in an insurance model, this is just not sustainable. So yeah, then I basically out of necessity created a different option.
Yeah. I mean, can you touch on that a little bit more, maybe for someone who hasn't experienced an ACL injury of like what the difference is, and what some of the limitations or barriers are with insurance?
Yeah, and again, there's the caveat to this is like there's definitely some really amazing clinics out there that almost basically are kind of specialties in and of themselves. I see that being the kind of almost only or best way for it to work in an insurance-based model. But like my mentor Laura at Build Physio in Montana and um, John Hodges at Nevada PT near in Reno. They are kind of like sort of not that they don't treat other things, but they're very specialized ACL injuries, and so they have it set up in a way where they only take certain insurances. They have affordable cash pay rates, things where they just know, and they're set up in a way where they can have these ACLers come and be there for 9 to 12 months, whereas in a regular generic orthopedic outpatient physical therapy clinic that takes all insurances and everything, they're pretty much dictated by what the insurance is going to approve. The issue there for an ACL injury is that even if somebody has no setbacks or no issues, which also is a little more rare, um, it is a 9 to 12 month situation, and very few insurances will approve people for that many visits, that length of time. Um, a lot of times, the level of testing that a high level athlete actually needs, which I'm sure we'll get to, is not available in that setting. Um, so there's just some limitations for sure. Others that come up oftentimes are, most of those clinics aren't set up for like space and equipment wise for a high level or a field or court sport athlete, where ideally when they're getting towards later stages, they're getting to full sprints, like having a turf long enough and space where there's like an area where they can shoot a basketball or like, do kind of drills like that. So yeah, I think the that's on the ACLer side limitation for sure. And then the other, what I ran into in addition to that was 90% of my caseload was ACL through the insurance model. There were a handful of people that I was writing a progress note for like every other week, because when they get to late stages, you have to continually be proving that they need more physical therapy. Whereas from the insurance side of things, as soon as they can kind of go through their day without any issues, which is very far from their sport, but on paper to the insurance company, they're really only responsible for them getting back to their day-to-day stuff.
Yep.
So that was a really hard, like fundamental difference between myself and insurance companies
Hmm.
that I was just dealing with so often. And it ended up in a handful of times like us having to discharge someone because they therefore couldn't afford the cash pay rate that my company was offering, but where I was working, which I totally understand, they need to run a business.
Hmm.
Um, and then they ended up back in the office a year later because they re-injured. Um, so yeah, that might be the most
Mm,
concise I can be on that, but it's really hard to do well in an insurance model without, and I know some people might not love hearing that, even other PTs, but the asterisk there is without the provider overextending themselves. And that's what happens because I was programming for people. Like people say, yeah, you can just come less often, which is, yeah, that's great. But then that provider is now, if they're doing what the ACLR needs and they, frankly give a shit, then like they're
mhm.
going to program for them and check in with them in between those sessions, none of which they're getting paid for.
Yep.
Um, so it was just really, I burnt out really fast and I didn't like it because it was doing actually what I love to do.
Mhm,
It was just not and I was afraid that I was going to stop loving it.
mhm. Well, I'm glad that you didn't and that you chose a different path because we need you and your
Yeah.
services and your voice. And now ACL Resolve has grown, right? Don't you have other clinicians or coaches that are working with you too?
Yes, I have two other coaches that work under me. They both have a handful of people, which is awesome. And yeah, I mean, like roster always fluctuates, but I think where we're at in terms of like total people we worked with is well over 100 now.
Awesome.
Not at one time,
Right.
but yeah, that's and really, really cool. Like I just started with somebody who is in Andorra, which is a country that I
Wow.
had never heard of.
Nope.
But it's interesting because like physical therapy is very different in different parts of the world. And it's crazy for us to think here, but like there are certain areas where it's like not really a high priority.
Mhm.
Especially in some areas that have like kind of, national based health systems. They can't consumer around their insurance and their medical and physiotherapy care. So yeah, there's some areas where like they'll get surgery and they basically get some exercises and get sent home.
Ugh,
So yeah, it's wild.
that's so wild. Yeah, that's pretty neat that you have that kind of reach too. I
Yeah,
love
the
that.
internet is an interesting place.
Yeah, absolutely. Well, we're gonna get back around to the rehab piece because I definitely want to touch more on that. But I want to back up a little bit and talk briefly just about anatomy for those who may not have a very good understanding. So, can you explain what the ACL does, what it is, and why tearing it can be such a devastating injury, especially for athletic individuals?
Yeah, definitely. So essentially, ACL is anterior cruciate ligament. You also have a PCL, which is your posterior cruciate ligament. The two of them basically create an X inside your knee. The ACL is super important. Well, they're both very important, actually. Both rehab processes are not super fun.
Mhm.
But the ACL in particular starts on the front side of your lower leg bone or your shin bone, essentially, and runs to the back. Of your top leg bone or your femur, your thigh bone. And essentially, what it does is, if you can sort of picture that, it prevents the bottom leg bone from sliding too far forward. There is some rotation that it also limits as well, but there's some other structures that help out with that in the knee. Um, and that is really important for overall joint stability, which again is probably kind of a random term for some people, but when you think about all of the forces that occur at, hip, knee, and ankle, but a lot of times at the knee, specifically because it's between the hip and the ankle with sporting type movements, it requires actually a lot of stability. And so when you don't have that same, um, what we would call kind of like passive stability, meaning the structures or the tissues are helping to you know, hold the joint in place slash have it work and move as optimally as possible, um, then you can run into things like instability, the feelings that people feel when they actually tear their ACL.
Mhm.
Um, why it matters also, and why it can be, in my opinion, like why I think it takes much longer than like a sprained ankle. Because technically that's a ligament too, right?
Mhm.
But like you can come back from a sprained ankle much faster. Um, the ACL being inside the joint, it doesn't have great blood supply, so it doesn't tend to heal as easily as other ligaments. The ACL also, they're finding, has a really important job in terms of communicating or basically sending what are called afferent signals to your brain about where your knee joint is in space. How, like, it helps a lot with balance and coordination of the lower extremities, legs. So when that essentially that crosstalk is now severed, it has a lot of kind of downstream effects in terms of what we call motor patterns, but basically how people are moving, um, their ability to develop strong legs again, like especially your quad muscles, those front thigh muscles. So there's a lot of some of those trickle down effects that I think aren't really as big an impact with some other injuries that make this one, it's built different.
Absolutely. Yeah, the whole everything in the joint, I think, is a big thing, at least from my understanding too, that it's like this is not we're not just talking about the ligament, we're talking about the entire knee joint and then of course, like we'll talk about, I'm sure, shortly, like then we're talking about all of the muscles that help stabilize the knee, particularly the quadriceps. And yeah, it goes on. So yeah, it can be a very devastating injury for athletes. And like you mentioned earlier, it's like a good 9 to 12 month process, at least, to get back. So I'd love to talk a little bit more about injury risk. I know, again, this is also a big topic that we're still learning a lot about, but can you talk about what some of the big potential risk factors for ACL injuries are, and then maybe touch on how those risk factors are different between males and females?
Mhm. Yeah, this is definitely going to allow me to go on some soapboxes here.
I love
So,
it. Please
um,
take it away. Take it away.
well, and I think, and we were talking briefly before this as well, but I think that there are lots of low-hanging fruit for, like, I'm not a huge fan of the word prevention because I don't really think, like, if you're going to engage in high-level sport, if you do it long enough, you're probably going to hurt something at some point. It's sort of like what you sort of know going in, especially if it's a contact or like semi-contact sport. Um, but honestly, the two highest predictors are either previous knee injury or ACL injury. And actually, well, this might not be the second one, but one of the other highest ones is not playing another sport. So, like, if you do literally only one sport all year round, your body only moves in the same ways. This is kind of like the theory. So, like, you know, when an ACL injury happens, which it happens really, really fast, and it pretty much always happens um, with the knee just slightly bent, you moving really fast and having to slow down and then change direction so that there's just enough of a rotational component that it puts the ACL in that position where it kind of just can't handle that load in that position. So again, it's like oftentimes just a slightly awkward position, but again, if you're put in that position and you're either fatigued because you're training all year round or you're you only know how to move in a certain set of ways because you only ever move those ways. That's part of the theory with that. But those two, I feel, if you tack on the third of just more regular strength training for youth athletes, that's the other hill I'll die on, is kind of like youth athletic development in our country. But those three pieces, in my opinion, like just overall lower strength, um, previous injury, and playing one sport all year round, if those were mitigated, meaning like you play even just two sports, um, you do some form of regular strength training, including in season, nothing crazy, and you're lucky enough to have not had a previous knee injury, um, I would be curious what what the rates might drop to. But obviously some of those things aren't in our control. The other things that are really big and floating out there that I actually hope that people can listen to this and maybe not feel so scared about is like especially on the female side, our anatomy. There isn't a lot of solid ground to stand on in terms of the research that there is anything basically making us doomed to have any injury at some point. Within that, there's been some research done on hormonal fluctuations in terms of laxity in our ligaments. I think in a small enough subset of people that might be more of an impact than others, but it probably more so has something to do with other systemic things like a hypermobility disorder or, EDS or something like that. There is some support for like essentially your notch. There's a little groove in both the shin and the femur, shin and thigh bones where the ACL and the PCL run, where if that space is more narrow, you may have more of a predisposition, or maybe I would swap predisposition with like maybe you just have a little less wiggle room with that scenario or that position that I was talking about before, um, in terms of it creating an environment 'cause it doesn't have as much space essentially. So a lot of times in those particular situations when they go to do the surgery, they'll do what's called a notchplasty and they'll make that bigger so that there's no chance for the new ACL to be impinged or anything like that. Um, Sorry, that was a sidestep. But but the other ones like hip width, like more of the anatomical pieces for males or females versus males. It just, in my opinion, like could it be a small percentage of the equation? Yeah, but I just don't know if I personally don't think it's enough to be like, you know, we have to coach everyone out of like, their knee coming slightly inward because their hips are wider and things like that. It just, there are so many situations in sport where that position happens and people are fine. Like, particularly in basketball, I know, like, can't necessarily pull up a video, but like, if you do a really fast crossover dribble, like, your knee dips in pretty low. If anyone has ever watched Kevin Durant play basketball, his knees buckle in all the time. And he's still playing in his 30s. Like, so, I mean, I know we can't compare ourselves to elite athletes, but, that I kind of bucket it into like, okay, what are those lower hanging fruit for us in terms of like, trying to vary how we move and play different sports, um, regularly strength train from a younger age. There's there's a couple of studies that actually show power lifters have like thicker ACLs, because they're just used to more head, like your tissues will respond to load. It's physics. So if we're starting to do some of those things, maybe just increasing the general capacity, robustness of all of our tissues, including muscles, um, from a younger age instead of just only playing your sport all the time, 7 days a week from the time that you're in fourth grade. Um, Again, I wonder what it would be.
Mhm.
So yeah, I don't know if that's specifically like it's probably more of like a it depends answer, which I know people don't love. Um, but
Yeah, and I think like there's a lot of talk now about how women and girls tend to be have higher incidence of this injury than boys and men. And, like you mentioned, the hip width or Q angle tends to be a big one that's talked about. And, you mentioned hormones too. Is there, I mean, in my opinion, it has, I think, a lot to do with that last point you made in terms of strength training, and that historically, like women and girls are not in the weight room from a young age. And I think the main difference is that boys and men usually are, or at least are more encouraged to do so from younger ages. And there's a lot of societal messaging around that for women as well. But I think, I wonder if, like you said, if women and girls were in the weight room earlier and actually lifting heavy weights, if we would see a difference there.
yeah, I mean that's, bias confirmation for me, but it's what I will plug in that area too is if anyone is interested, Joanne Parsons is the author. I can send you this to link it if you want. But in 2021, she wrote a paper called Towards a Gender Approach in ACL Rehab. And super, like, she explains what I feel like I was trying to get at for so long in such a much more eloquent way and with research to back it, more qualitative research versus quantitative, but really considering how women and girls are brought up, at least in our kind of like Western society, um, how there is absolutely no way in terms of ACL injuries that we can't consider that essentially like, if not a risk factor, just like a pretty big piece of the puzzle. And actually, I would say not even a puzzle piece, basically the whole backdrop, like the table that you're building the puzzle on. Because it's like our motor patterns are literally programmed to be, in most cases, like obviously there's exceptions, but as back to the classic, like boys are sent outside and they run around with trucks and sport balls, and we're kind of, told to behave and play with dolls. And that's very oversimplification, but in general, there's, two different spectrums that we're on from a motor pattern development standpoint. It's very different for most of boys versus girls when they're growing up. So I can send that link to you, but that is, the short answer is I think it would be significantly different. Um, and I would also go as far to say that like even in our younger male athletes, I think there's probably they could be doing some of that. It's already shown to be safe, to start by ages like 9, 10, 11. Like, they're not throwing barbells on their back, but just having something more than, learning squat and hinge patterns, lunges, like marching, sprint, like all of this stuff. The Again, thinking about trickle down effects, like they're all building blocks of all the stuff that they're going to do in sports. Um, and it's crazy. Like I've worked with some pretty elite level athletes that like can't stand on one leg well or can't like, do some A skips or something like that. So it's yeah, all of the above. Answer E.
Yeah. 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 And I mean, we could dive down a million other rabbit holes with this, but there really is a lot of different things that I wish were a little bit different. And, it's hard to have that roll out on a broad scale. But I want the audience to come away with a few takeaways here. So if you could pick a few things that you think are like would like to see happen on a broader scale to reduce the overall risk for ACL injuries, like what would those be? Especially, most of my audience is cisgender female, so we're gonna say particularly for women, what would be your top things that you would like to see change in order for reduced risk of injury?
Yeah, I would say not playing one sport all year round. I think that goes across the board, but also I do think, I don't know if there's specific research on this, there probably is, but I do think that there is um, I don't know if it's more or less for males versus females, but I have seen a lot of female athletes specializing really early, meaning like they have a skills coach, they have if they're lucky, they also have a strength coach, but that's very rare. I think that's probably in like very elite or financially able situations, or if their team may have it, which is great. But it's not only just playing soccer all year round. It's like, and not just soccer, I'm using that as an example, but it's not having like there's no downtime, there's no off season. And so I think that that tends to go hand in hand. And that's maybe not something I mentioned as clearly before is like, it's not if you're playing even two similar sports a year, but you have like one season off, that's also going to be better than playing one or even probably two sports all year round with no downtime.
Hmm.
So I think that that's super huge. One thing I didn't mention, but I do think specifically for females, it's also a low-hanging fruit is fueling is like and eating enough is developmentally and actually with your performance. Um, make that a normal thing versus needing to be more fit, more lean than your teammates or club team members that you're technically competing against for like, college visits or whatever. Um, you will do worse if you are not. And again, I understand that in some situations that's especially teenage years, like that's going to be really hard, but gosh, the number of female athletes and even beyond like high school and college female athletes that I've worked with, and I was one of them, 100%. Like that's, I actually think it's a big factor that went into my injury.
Mm,
But I just feel like, and it doesn't even have to be anything crazy. It could be like eat breakfast. You know what I mean?
mhm.
It is probably for most adolescents, but I just think it hits females harder.
Yep.
Um, I think that would be, to make it more concrete, like eating enough good quality food, um, especially when you are training so much. You probably, I can venture to guess you definitely need more than you think you do.
Mhm.
Um, so that's two. I think the last one I would say is just starting strength training earlier. And for the love of Pete, not body weight band tone stuff, like
Yes.
hold some weights, try a bar once you're old enough and feel comfortable. Um, Machines are not bad, not a bad thing. I just think that would, if that was made more normal, especially in high school sports, like after or before practice, the football team was always in there.
Mhm.
Why wouldn't other teams like basically have a turn in there, like the wrestling team, the football team? Yeah, actually, I don't think the men's soccer team was ever in there, but like, and that's it's very cultural, I think, based on sport
Mhm.
and on gender. So yeah, I think those would be my big three.
Yeah, love that. Yeah, that's great. And I wholeheartedly agree. Um, I think how many years ago was that? The NCAA March Madness
Yeah,
drama. That was
2020 or 2021. It was definitely COVID.
it was COVID times. That's right. And it was huge. I'm sure most people listening remember this. It was like they show the weight rooms between the men's team and the women's team at the March Madness tournament. And the women had like a tree of little dumbbells, and the men had like a full-fledged,
Olympic lifting platforms.
yeah, like just a massive amount of like resources and equipment, and that's when we were like, rehab providers and fitness and everybody alike was like, this is the problem. Like this is the exact perfect illustration of the issue of both injury risk and also just so many other facets of the lack of resources and support in women's sports.
Yeah.
So the Load Women event, I don't know if you've seen this. Yeah, okay. So I think it's Claire Zai
There.
and
Mhm.
yeah, and Alyssa Olenek are running this campaign now that I love, and it's just I think it's like every spring. They just try to spread awareness about the importance of loading women, and really making sure that women are strength training. So definitely, if you're listening, you haven't heard of that, go check it out. They do merch, and they do challenges, and they do like just general awareness stuff. And I've shared it quite a bit on my stories, but I'll keep continuing to do that. All right, let's move on because I know are on limited amount of time and there's so much to go into. So, we used to really think that if you tore your ACL and you wanted to get back to sports, you had to go get a reconstruction. Now we're starting to see that your ACL can, in some people, heal spontaneously or naturally. Can you touch a little bit on this in terms of like your experience with athletes and kind of that decision at the beginning of whether they should try for surgery or whether they should go the non-operative route?
Yeah, I love when someone, like if I have a consult with someone or they reach out and they're um hey, I had surgery, I'm not, or I had an ACL injury, I don't know if I'm getting surgery, and I'm like, awesome, let's chat. Yeah, when I tore mine, I didn't have a choice. The only I was told, okay, you're swelling down, get full extension, and then we're operating.
Hmm.
So what I usually tell people in terms of do you need surgery? Not necessarily. And here's how I usually advise people on whether or not they would be a better candidate for surgery, probably, versus I would give this like 3 to 6 months of, you know, very targeted prehab, just in case you do end up getting surgery, but essentially like a conservative approach and see based on your goals. And those things are if someone is several weeks out already and they still have a lot of swelling, they're having trouble getting full range of motion, lots of pain, and particularly they have a lot of what we would call instability episodes, or the knee feels like it's giving out on them, like whenever they're walking or, anytime they make a turn. And that doesn't seem to be changing in the first few weeks. It's a sign that potentially the knee slash your body is just not responding super well to the injury. That person could still say, like, if they're determined, they could say, yeah, I'm gonna wait like 3 months and see what I can get done. But usually in that first like 2 to 4 weeks, if there isn't a pretty significant change in those things, meaning swelling, pain, um, range of motion, and instability episodes, or the knee feeling like it's giving out on you, then I would say that person is probably maybe not going to end up being the best candidate to not have surgery. Their body is telling them like, yeah, we really do need that extra internal stability, like from a structure standpoint. Um, if I'm talking to someone again in that like 2 to 4 weeks post-op, and swelling's come down a bit, they have pretty good range of motion, their quad is working pretty well. That's one other thing I forgot to mention in the not doing so well scenario. Like it's really hard for you to actually fire and squeeze your quad muscles and straighten your knee actively. But if all that's going well for them, they're walking normal up and down stairs. Some people have said they've like tried running a month later and like they're not really having any instability episodes. It feels pretty similar to the other side, other than like, there's probably still a little bit of pain. There might be some laxity. Um, those people I tell, like, if you're not on a specific timeline, I would wait. Um, I would, again, get any range that you need, get the rest of your swelling down, focus on a ton of quad stuff, and really see how you're feeling. Because two things, there is a subset of the population where there is evidence on MRI of some healing, a year later. There is an entire protocol now called the cross bracing protocol, where if somebody wants to try conservative, you do, I believe, need to start this protocol like within the first 2 to 3 weeks of the initial injury. So if people aren't aware of it and then they find it at 6 weeks out, like might be a little bit too late, but essentially you keep your knee bent at 90 degrees for like a long time. I forget if it's like 4 or 6 weeks. It might be even a little longer than that. The point being, or the idea with this protocol being that it does make the two, if you think about the ACL itself, and let's say it's severed in the middle. Usually it's closer to the top part, but either way, the idea is that the two broken ends get approximated, or they come a little bit closer together when your knee is bent at that range. And it could potentially, with again, they want the swelling in there, they want all of those the nerdy stuff we learned in school, like anti-inflammatory stuff going, or inflammatory stuff going into the joint to essentially start the healing process as best it can with those fibers close together in hopes that the body's really smart. So sometimes in some people it does kind of like know to, have some of those fibers sort of adhere back together. Um, their rates were pretty good in the initial study, but again, it is like people need to know about it and like follow it to a T, which for a lot of people's life, that's just really hard to do.
Totally.
Um, so the shorter answer is like if even aside from the potential for healing, like even like if that person's ACL never heals, but the body seems to not be freaking out that it had an ACL injury, and it seems like they still have decent like, brain muscle in terms of quad connection. Like I don't I don't know if I would recommend surgery unless, again, we're talking about like somebody has a season coming up that's like a very high level sport. Because I've also worked with a good number of people who, even without evidence of healing, have gone back to like skiing, trail running. Like, does their knee feel exactly the same as the other one? Probably not. Like it, and that's not necessarily, I feel like, the expectation anyone should have. Um, which is another thing I wish someone told me.
Right?
Yeah.
Like,
Yeah,
yeah,
yeah.
even after getting operated on.
Oh, sometimes even more so. Like
Yep.
sometimes the people that don't end up getting surgery and do well, again, it is like it might not be you. So if you're listening to this and you're like, I hate you for saying that, like I definitely needed surgery, like there absolutely is some people like I was having a lot of instability. I didn't have like a ton of swelling or anything, but I needed the surgery. So like there's definitely it's obviously we need to have the surgery as an option. But there does seem to be some people, I think there's also like some personalities that are just like okay with like, yeah, let me try it. Um, the next question that I always get is like, well, aren't I just gonna like tear my meniscus or get arthritis then if I don't have like because the knee's moving around a little bit more? And like intuitively that makes sense. But the research says that the rates of like post-traumatic osteoarthritis are pretty similar whether you get surgery or not. The theory with that is that it's more the initial inflammatory response and the trauma of the actual injury that creates the environment for more early arthritis than the laxity itself. Um, I can try to find that paper, but I know I read it at some point, but
Yes.
that's sometimes hard for people to grasp too. So the answer, you don't necessarily have to. And a lot of people, I actually wish more people, again, if they have the luxury of time on their hands in terms of knowing that the end result may still be surgery, I wish a lot more people would try like 3 months of rehab and just kind of like see.
Yeah. That's like newer-ish, especially for a lot of people that are in listening to this. They're like, what? That's an option?
Mhm.
So yeah, I love that.
Yes.
Okay, so I want to talk a little bit about the actual rehab, both before you get surgery, but especially after reconstruction. But I want to take kind of a zoomed out approach because we could spend hours just on this part right here. So, like from a zoomed out approach, what are the big things that someone should expect after ACL reconstruction in terms of rehab? And, we already kind of touched on timeline earlier, but any general advice or things that you think people should expect during the rehab process?
Yeah, definitely. I think there's a way I could probably do this macro without being like, yeah, and then at week 9 you start this. Um, because you know my opinions on timelines.
Yes.
Um, but I think I like to chunk it kind of like I think the early stuff is really important because I actually think that people think that early rehab is easy. And it's the thing that most often gets effed up.
Hmm.
um, unfortunately. So in the early phase post-op, and again, this is going, what I'm going to say right now actually isn't necessarily considering meniscus or any other kind of like concomitant thing that they had to do, but like a straight up kind of routine ACL reconstruction. Your priorities should be getting swelling down, getting your quads working, getting whatever range that you're allowed if you have any limitations, um, getting normal walking, and not trying to do all the things. I think that like sometimes people think like, okay, week 2, I need to be like getting rid of my crutches. To be honest, I'd rather you keep one crutch or two crutches for longer and actually get rid of the brace so that you can do normal walking first. Um, then get rid of the crutches and just be walking around on a peg leg with your brace, which we see like way too often. But then the bigger picture things are whoever you are working with should be able to tell you how you're going to progress, what they're going to use to be able to tell you are ready to progress, what you can expect in terms of work that you need to put in and the commitment that you need to put in and outside of the clinic, depending on what medium you're doing this through. Um, and they should be addressing specifically any like it should be normal and you should feel okay talking about like things that you're hesitant with or you're fearful of or you're not really sure or like right now I can't go to the bathroom by myself. How do I like that should be very normal because I think that there are too many situations where there's a lot to do in the early phase and nobody actually kind of checks in with you. Um, and there's usually a lot of shit swirling around up there. Um, so yeah, I think that's like early slash kind of setting expectations. Like this should be somebody who has clearly done this before.
Hmm.
Um, if they are, and then if we're talking about like middle and late, I think in general, things that you need to feel like are in your plan or your program is some form of formal strength testing. Um, that can be isokinetic or isometric, but essentially it's not just you pushing into your PT's hand. There needs to be a device that is measuring how hard that you are kicking. Um, at this point in time, with the accessibility of testing equipment and the cost of some really decent baseline levels for those things, it's kind of malpractice to not, again, that's my opinion, but it's
Hmm.
borderline malpractice to not be using that as at least part of the decision-making process for, like we have a range that we want people to be in before we go to return to running. Instead of it just being week 12, we do this because some people are ready and some people are not. Some people are ready at like 10 weeks. It's different.
Hmm.
There should be levels where people are at before cutting and change of direction and more return to sport stuff. Um, so there should be some formal strength testing and a small battery of tests at least that they use to be able to tell that you are ready. And that's something again, like there's a million and one ways exercise wise to get people there. So that's not really worth kind of getting into. But if they don't have an overall general plan and they don't have a way to straight up measure said progress in terms of progressing you, those are red flags.
Yeah. Yeah. So big things I'm hearing are lack of testing, actually backing up, lack of set expectations from the beginning, lack of formal testing to actually tell you where you're at and how you're doing and how you're going to progress, not just going based off of oh, you're at 6 weeks, time to take off the brace, and oh, you're at 12 weeks, let's start running. There actually needs to be testing done to make sure objectively that you're ready for that, and also talking about like this would be a whole other topic, but like the psychological impact
Mhm.
and how you're doing psychologically can also impact how you're progressing. And then, yeah, someone who is actually paying attention to your end goals and progressing your program. So if you're seeing the same thing over and over and over and over again, that's also a red flag. Did I miss
Yep.
anything?
No, I think you nailed it. And there's also pretty strong research for that psychological component impacting successful return to sport also.
Yeah. Okay. So again, we could talk a lot longer about all of this stuff, but I want to respect your time and start to wrap up here. So, um, is there anything like any big rocks that we may have missed in this discussion that you feel like are worth mentioning here, or any major myths or misconceptions that you hear commonly about ACL injuries or ACL reconstruction that you want to squash? Anything you want people to take away from today?
Um, I think we talked about most of them because usually I try to sneak in something about fueling.
Mm-hmm. Mm-hmm.
Because I mean, the idea was started with me because I had the experience, but I really do wonder if, again, I'm sure I would have gotten injured at some point, but I wonder if would have been as catastrophic if I had not been chronically underfueled. And, I've talked about that before, and I think it had a lot of impact, positive impact for me in some ways, but also like, you know, some things that I even still deal with from that period of time, that long period of time where under eating, over exercising, not sleeping enough. So if people hear nothing else from like a not even injury risk reduction, but like successful athletic career, like sleep enough, eat and drink enough, strength train a little, uh, take mental and physical breaks when you need to, even though it's usually the time in your life where everybody thinks, you have to go, go, go and be ahead. Um, and then I think maybe one other thing that maybe is newer for some people, maybe not as much clinicians, but potentially ACLers themselves. I touched a little bit on the some of the neurological stuff that happens with this injury because of that kind of crosstalk between the ACL and the brain and the nervous system. But um, something called arthrogenic muscle inhibition happens really to everyone after the injury for a little while. And all it really means is that your brain shuts down your quads on purpose, like as a protective measure, because you had a major injury. And then they also went in, if you had surgery, they went in and like created a whole bunch. I mean, they drill into your bone, it's a lot of trauma. So your body's reaction is, I don't want to put weight on this leg. So I'm just not going to send any juice essentially to the quads because you can't really functionally walk well or put weight on your knee without the quad working. So all that being said, it is something that happens to some degree after, like to everyone, but there is a subset of the population where it can linger. And so I think the other thing that is really important in terms of you know, something to maybe ask a provider about and make sure that they kind of know what's up in terms of how do you combat that. There are things early on that are helpful with it that have been shown. So one of the things is NMES, which is those little kind of electrodes that go on your leg and they actually make the muscle contract. It's not going to get rid of the inhibition, but it can mitigate some of the atrophy that happens. And it also kind of just helps stimulate the muscles. That other piece is really getting swelling down. Icing the joint right before you do exercise can help with that inhibition. The long story short is that there are ways that have been shown to or interventions that have been shown to really help kind of get AMI out of your system early and often if possible. Um, so there's two things. Either if the provider doesn't really know, it doesn't seem like they know intimately what you're talking about if you ask them about that, like if this is a concern, like how do we go about treating that? Or if it's a situation where they seem to be pretty lax on swelling, meaning they'll kind of allow or have you push through an increase in swelling or pain, especially early. That is a huge no because swelling will perpetuate the cycle of that inhibition. So again, I know that's maybe a little bit of a niche piece, but it is something from the early stages that if the ACLer is aware and they happen to be with a clinician who maybe isn't as experienced with that happening, and then it does happen to them, that has a lot of they could potentially switch a provider early enough where they're kind of in the clear versus if that lingers, it doesn't bode well for, overall success and outcomes.
Yeah, long term. Right. Yeah, it can
Yes.
really impact downstream. Yeah, for
Yep.
sure. I'm glad you mentioned that. Yeah, and a lot of that too, that you mentioned about fueling and managing load and sleep and all of that is not only important during the rehab period, but also like you mentioned for injury risk reduction and just overall performance as an athlete. And that's also gonna impact then hopefully potentially re-tear rate or tearing the opposite knee, which we didn't even get to touch on that today,
Yeah.
but that's a whole nother rabbit hole. Um,
Yes. There are
but
many.
yes, there are. There absolutely are. Okay, this was awesome, Steph. Thank you so much for your time and expertise on this. If people want to learn more from you, learn more about ACL Resolve, how can they get in touch with you?
Yeah, so most active slash comfortable with and on Instagram. I'm just Steph Allen.dpt. Our ACL Resolve website is just literally aclresolve.com. Maybe some more on the clinician side if they're interested from that end. Again, also Instagram or clinical athlete. That's where I do most of my mentoring through there. So that's either just clinical athlete on Instagram or clinicalathlete.com. And yeah, I think that's about it.
Yeah, I love it. Definitely gonna link all of that stuff in the show notes. I think if there's no other takeaways from today's episode, it's please, if you're dealing with this injury or you know someone dealing with this injury, find a provider who knows what they're doing, like Steph, who's actually gonna put in the work to be a partner for you through that process and just be an excellent guide and help you get back to doing the things you want to do and just feel as normal as possible again. So, thank you again, Steph, so much for being here. I really appreciate you. And if you're listening and you like this episode, please leave a rating or review or share it with someone who you think might benefit. And that is it for today. I will talk to you again next time.